So, as we all know, pre-oxygenation could be a life-saving procedure when trying to manage the difficult airway. Previously, pre-oxygenation has been performed using a tight-fitting face mask, and lately also using humidified high-flow nasal oxygen. There could, however, be clinical scenarios where a standard nasal cannula is the only available option for oxygen delivery, why we in this study wanted to investigate the pre-oxygenation efficacy from using a standard nasal cannula. In the study, we recruited 20 cardiopulmonary healthy volunteers who, in a crossover design, were pre-oxygenated with a tight face mask, humidified high-flow nasal oxygen, and a standard nasal cannula. All three methods were investigated repeatedly at different oxygen flow rates using both open and closed mouth breathing, as well as during vital capacity maneuvers and 3 minutes of tidal volume breathing. The primary outcome of the study compared end-tidal oxygen levels after 3 minutes of pre-oxygenation. Our results showed that 3 methods were superior to the rest. Face mask pre-oxygenation using 3 minutes of tidal volume breathing, humidified high-flow nasal oxygen at a flow rate of 50 liters per minute using closed mouth breathing, and lastly, the standard nasal cannula using a flow rate of 50 liters per minute and closed mouth breathing. Although the standard nasal cannula was less comfortable compared to the other methods, it still demonstrated high efficacy. While it may not be suitable for routine use due to comfort issues, its global availability, low cost, and ease of use make it a valuable option in clinical emergencies or when other methods are unavailable. For all flow rates using any of the 2 binasal cannulas, pre-oxygenation efficacy was significantly improved when breathing with a closed mouth compared to open mouth breathing. Open mouth breathing did not generate end-tidal oxygen levels above 80%, even at flow rates of 50 liters per minute. We hypothesize that the improved efficacy seen from closed mouth breathing is mainly due to less entrainment of room air and a higher actual fraction of oxygen. This could be of clinical relevance, especially in patients suffering from respiratory distress, unable to breathe with a closed mouth. In these patients, pre-oxygenation with a binasal cannula should be avoided and instead performed using a tight-fitting face mask. One proposed advantage of using a nasal cannula is the ability to communicate with patients and ask routine preoperative questions during pre-oxygenation. In our study, we examined end-tidal oxygen levels in volunteers who spoke during 3 minutes of pre-ox. We found that end-tidal oxygen levels were below 70% when talking during pre-oxygenation, leading us to recommend asking all preoperative questions before initiating pre-oxygenation. So in our study, we saw that pre-oxygenation efficacy was improved when breathing with a closed mouth compared to open mouth breathing via any of the 2 nasal cannulas. Previous studies have also shown that closed mouth breathing using humidified high-flow nasal oxygen generates a positive end expiratory pressures with increased end expiratory lung volumes. This suggests that closed mouth breathing might not only enhance pre-oxygenation efficacy, but also its efficiency by increasing functional residual capacity and enhancing oxygen storage. So in our study, we showed that vital capacity maneuvers via a tight-fitting face mask could be used as a non-inferior option to 3 minutes of tidal volume breathing. 7 vital capacity breaths were required to achieve end-tidal oxygen levels equal to 3 minutes of tidal volume breathing via the face mask. 4 vital capacity breaths, however, were not enough to generate an efficacy equal to 3 minutes of tidal volume breathing via the face mask. Vital capacity maneuvers via any of the 2 nasal cannulas generated poor pre-oxygenation efficacy, even though oxygen flow rates of up to 50 liters per minute were used. This was especially true during vital capacity maneuvers with an open mouth. Most likely, this is due to a peak inspiratory flow exceeding the oxygen flow rate with increased entrainment of room air. So, in clinical emergencies, when induction of anesthesia needs to be performed immediately, we therefore recommend using 8 vital capacity breaths via a tight-fitting face mask.